Good morning and welcome to Axxess's webinar on the Home Health Conditions of Participation Overview. This is a question and answer type format today. We will be going through our presentation but taking questions regarding home health COP regulations as well today. So I want to welcome you. My name is Jennifer Gibson. I'm a senior clinical consultant here at Axxess. I'm an RN with many years of home health experience. I started my home health career in November 1993 after being a med-surg urology nurse for a period of time, and I'm here to help guide you through the whys of why we've made certain functionality changes in the Axxess Agency Core product today. So let's go ahead and get started. So just to note, the slides that you're going to see today and receive in the future via the email in which you registered, just want to let you know that these slides are not all inclusive of all of the conditions of participation, and they're only meant to be cue points. So everything that I say today is not going to be in the content of those slides when you get those. And those slides are also copyrighted, and you'll need to get my permission or the permission of Axxess to use those further. So let's have a look at some of the new regulations. We're going to talk about the overview and insights in certain selected standards from the conditions of participation. We're going to talk briefly about patient rights, about the content of the comprehensive assessment, about the plan of care, about the coordination of care, written information that's required to be given to the patient, and then we'll touch a little bit on infection prevention and control, and also the requirements of skilled professionals. We're not going to spend a lot of time here on the slide regarding notification of patient rights, but what I do want to make sure you're aware of is that depending on what type and deadline you have, you're going to have to document the notification of rights a little differently. For example, we see that the patient and the legal representative must be notified in written form before care is initiated. That means on the initial visit, before you do any teaching or any kind of hands-on care, including a head-to-toe assessment, the patient must be notified of his or her rights, and then you have to have an acknowledgement of that and a consent to go ahead and provide care. That doesn't necessarily mean that you have actually admitted the patient yet, because the initial assessment is to see if that patient requires care and what care they require, as well as whether or not they meet the criteria for receiving the Medicare beneficiary, including homebound status. However, it is here that you do have to get that patient an overview of their rights in written form. Just to note, by the way, when we say written form, the interpretive guidance, the draft copy, which is all we have at the time of this broadcast, does clarify that written means you have to give them a hard copy unless the patient or their legal representative request an electronic copy specifically. Otherwise, you do have to give this in written form. We also see that the patient's chosen representative, which we know might be a neighbor or a church friend or whomever, has to receive a written copy of the patient rights within 4 business days. This is where part of your coordination of care is going to come in, making sure that within that 4th business day, someone has a written copy delivered to that patient chosen representative. And again, this will need to be documented in the patient's record, because this is above and beyond that original consent form that you may have where the patient initials that they received a written copy of rights. And then lastly, you see that the patient and or his or her representative must have a verbal notification of patient rights in their language of preference by the 2nd skilled visit. And again, we have to think about coordination of care here, because if that 2nd skilled visit happens the very next day, the person going out, that skilled professional, needs to know what language the patient speaks, how to reach interpretive services if needed, and or who to coordinate the visit with if the patient's choosing a family member or a neighbor to be their interpreter. So all of that's going to need to be documented in your record to make sure that the surveyor, who will be looking for all of this, is able to easily find that these 4 parts of patient right notification have been met. Speaking of patient rights, let's get into some of the patient rights. And again, we're not going to go through all of them, but I do want to highlight those patient rights that are directly tied to our plan of care and our coordination of care and other pieces that we're going to see in just a bit. We see, first of all, in the overview with patient rights at 484.50C that the patient has the right to participate in and they're participating in their treatment, to be informed about their treatment and to consent or refuse care in advance of and during treatment where appropriate. One of the first things they taught us in nursing school, and I speak as a nurse because that's what I am, but I'm sure the rest of you professionals also got this education, that part of preparing for a treatment or for preparing for care is to prepare by gathering your supplies and explaining the procedure to the patient. So even though home health care may not all be hands-on procedures, we still have the responsibility, I should say, to make sure the patient understands what it is we're going to be doing for him or her, and they have the right to consent or refuse that care before it happens, or even as late as right before you're getting ready to do it or during that treatment. And what they're talking about specifically here in this standard is that this applies to the completion of all assessments. It applies to the care that's going to be furnished based on that comprehensive assessment. It applies to the establishment and revision of the plan of care. It also applies to the patient being able to participate in and consent or refuse the disciplines who are going to furnish care, the frequency of the visits that will be provided, and then expected outcomes of care, including patient-identified goals and anticipated risks and benefits. So all of those are things that the patient gets to participate in planning and refusing. We also see here at 48450C3, 7 and 8, any factors that could impact treatment and effectiveness and any changes in the care to be furnished. The patient has the right. And we know particularly that the surveyors and CMS are very stringent about ensuring the patient's rights are protected. So again, you're going to want to make sure your documentation spells out that this patient was given the information, they were informed about what was going to be happening, and they had the right to consent and refuse or to contribute to that plan of care as needed. Now this becomes a big deal too when we start talking about the comprehensive assessment and the coordination of care, because as we see here at 484.50C5, there's a new standard that says the patient has the right to receive all services outlined in the plan of care. That's very important to know, because once this patient is admitted to care and the clinician is out doing that head-to-toe assessment and the comprehensive assessment, they are already or should already be thinking about what this patient needs specifically and individualizing a plan of care in their mind. And that's very important, because once we have the plan of care created, the patient has the right to receive all the services that are outlined in the plan of care. And you're going to see this tied into many different pieces of regulation in the COPs, especially that where we see that over and over it's stated that this needs to be a patient-specific, individualized plan of care. So gone are those days of getting plans of care that are done by someone else in the office and not the assessing clinician, or plans of care that are just blanket statements like skilled nurse to teach on disease processes and medications. CMS and the regulation here, they're really looking for what specifically this patient needs. You shouldn't have situations where you have 10 CHF patients who continue to have exactly the same plan of care. They should be different in each and every way in each and every case. All right, we see at 484.55C the content of the comprehensive assessment. We see that the comprehensive assessment must contain the patient's current health, psychosocial, functional, and cognitive status. And I want to stop just a moment and let you know that two of those in that first bullet are new standards. The psychosocial and cognitive status particularly are new to the comprehensive assessment. That's why when you go into your agency core system and you look into the new OASIS C2 document that we have, that was upgraded so that we could add those indicators for psychosocial and cognitive status. And those different pieces will now flow over to your plan of care and give you the ability to identify that and make sure it is on the plan of care. And you're going to see that on the standards in just a bit, that actually has to be in the plan of care itself. The comprehensive assessment must also have the patient's strengths, goals, and care preferences and information that can be used to demonstrate the patient's progress toward the achievement of goals identified by the patient and the measurable outcomes identified by the agency. Again, we want to think about here the patient's strengths and goals. What is it that they are good at? Maybe they have a better financial situation than most patients, and that's going to help them reach their goals. Or maybe they have a higher education level, or they have a family member who had diabetes and now they have diabetes, so they're going to be able to have some familiarity with what they're supposed to do. And then what's that patient's goals? Are they trying to walk to the mailbox when they're primarily bedbound now, or do they have realistic goals for their care? Those are some things that we're going to be documenting in this comprehensive assessment. And then what are their care preferences? For example, if they want a tub bath rather than a shower bath, or if they prefer their care to be in the morning instead of the afternoon, we see in the interpretive guidance that those types of care preferences should be accommodated as much as possible. So again, we're seeing that we are going to bear more responsibility and more patient-centered care measures in not only our comprehensive assessment, but also in the delivery of the care that's given. The other thing to point out here in the second bullet is that the patient's progress toward achievement of the goals that we've identified. Again, this is something that if you've ever done chart reviews, you may laugh with me about this. Sometimes you're looking at a chart and you'll notice when you're reading that chart, the patient is described as having all these issues and not doing well, and they still need home health services and so on, until you get just up to the discharge visit, and then suddenly it appears that a miracle has happened and this patient's now discharged. We don't want that to be the flow of the record today. You want this chart to really progress from the time they're admitted and you're seeing little steps of progression toward their outcomes, and then finally the discharge happens, right? We also see the content of the comprehensive assessment must have the patient's continuing need for home care, the patient's medical, nursing, rehabilitative, social, and discharge planning needs, and then a review of all the medications the patient is currently using in order to identify any potential adverse effects and drug reactions, including ineffective drug therapy, significant side effects, significant drug interactions, duplicate drug therapy, and noncompliance with drug therapy. Again, this should be on an ongoing basis, but in the comprehensive assessments, we need to talk about why they need home care, and you're going to see specific sections in that OASIS C2 that allow you to document that medical necessity very thoroughly and very well, and then what their planning needs are for medical, nursing, rehab, social, and discharge needs. And then, of course, it's always been a requirement to do a medication review. When they talk about all medications, of course, they're talking about oral, they're talking about inhaled, topical, whatever way it's delivered, peg tube, all of those medications, including over-the-counter drugs and herbals, which may or may not be on your discharge summary orders, right? So that's why we have this big job of going in and identifying all the medications, making sure they're all recorded. We do a drug review and reconciliation, and then we communicate any findings with our physician and look for all kinds of problems that could happen, duplicates, ineffective drug therapy, and so on. The comprehensive assessment must also record the patient's primary caregivers, if they have any, and other supports such as legal representative, or they have Meals on Wheels, or they have a neighbor who helps, whatever. All of that needs to be in your comprehensive assessment. And then we also have to include their willingness and ability to provide care and their availability and schedules. Now, because this can be difficult information to obtain, we have in our new patient form on referral intake the ability to go ahead and add this information if you have it from the referral source to begin with. And we highly recommend that you train your referral intake persons to get as much information as possible from your referral source, including things such as the primary language the patient speaks, whether or not they have legal representatives and or caregivers and or patient-appointed representatives, any diagnoses that you may be able to obtain, and so on, because all of that can be put in on referral and give you a better picture of the care you're going to be providing for this patient. It will help your new clinical manager assign more appropriately the staff members going to see them, and so on. And then if this information is entered in the new patient form on referral intake, it will flow over into your OASIS. And if it happens to not be exactly correct, most of those items you have the ability to go ahead and amend in your OASIS as well. The comprehensive assessment must be updated and revised as frequently as the patient's condition warrants. due to a major decline or improvement in the patient's health status. And I'm going to stop right there because this is a kind of a concept that's new again. We used to see this all the time when PPS first came into play. If we had a patient who got a lot better or a lot worse and we needed to adjust their payment mid-cert period, we had the ability to do a follow-up assessment, which we often referred to as a SCIC, Significant Change in Condition, or SCIC, and that would recalculate the payment and adjust it midstream. But as PPS progressed and evolved, that went away, and we ended up doing that at the end when we did our final bill, and it's now only based on the number of therapy visits. Things such as changes in diagnoses, sequencing, and all of those different things, they don't get updated for payment. It's only the number of therapy visits that is now considered. However, we see here in the updated COPs for the comprehensive assessment, if the patient's condition unexpectedly improves or declines to the point where you need to do a major change in their plan of care, you need to go ahead and do a follow-up assessment or a significant change in condition assessment, which will, by the way, generate a new plan of care for you. And according to this standard, that comprehensive assessment must be updated and revised as frequently as their condition warrants due to major decline or improvement, but no less frequently than the last 5 days of every 60-day period, and that date starts calculating on the start of care date, or within 48 hours of a patient's return from a hospital admission or at discharge. So the last three bullets are not different than what we're currently doing, but that new reintroduction of the significant change in condition assessment is new, and I just want to point out to you once more that when you do the follow-up assessment, it will generate a new plan of care that can be sent for physician review and signature. At 484.60A in the plan of care, we see that the patient must receive the home health services that are written in an individualized plan of care that identifies patient-specific measurable outcomes and goals. Again, we see this tied to the patient's rights. This is the second time we've seen CMS point out that whatever ends up on our plan of care, the patient must receive those services. So again, we have to make sure that our assessment is complete enough that we have a patient-specific, measurable, individualized plan of care that has measurable outcomes and goals. So you're going to need to do things like include specific dates on your goals as to when you plan for these goals to be met. If you're not really sure about those dates, you're going to give your best estimate, and you may have to adjust those at the next cert period. But we are expected here to make sure that they're patient-specific and measurable outcomes and goals. The individualized plan of care must also include the following: mental, psychosocial, and cognitive status. Again, we just saw that in part of the comprehensive assessment. Now we see where I was talking about how that's going to need to flow over to your plan of care, and that's why you have that functionality in your new OASIS C2 as well. We also see that the plan of care must include a description of that patient's risk for emergency department visits and hospital readmissions and all necessary interventions to address that underlying risk factor or factors. Again, you're going to see in the OASIS C2 new documents that have been updated. You'll have two different hospital readmission assessments to use. Your agency policy will dictate whether or not you're going to use one over the other or both. That's going to be an agency decision, but we've given you a couple of options there. And as I said, those will also flow over onto your plan of care as well. The individualized plan of care must also include the patient and caregiver education and training to facilitate a timely discharge. Now again, remember, home health was designed not to be a long-term solution. And we're not there for, what is the word I'm looking for? We're not there for, long-term custodial type care. We're there to help teach the patient and family and caregivers or whomever's taking care of this patient how to care for themselves during an acute episode of illness. And we're to teach them how to manage their comorbid conditions, for example. So for that reason, CMS is looking that we are actually thinking about discharge from the very beginning, and we're planning for a discharge. And so on our plan of care, we have to have patient and caregiver education and training outlined so that we can see, or CMS can see, the surveyors can see that we're planning on that timely discharge. We must also have patient-specific interventions in education, measurable outcomes and goals identified by the agency and the patient together, and then information related to any advance directives. All patient care orders, including verbal orders, must be recorded in the plan of care. And I know we've had some questions about this already with the functionality. Let me just say a couple things about the plan of care that you're going to see in agency core since our updates. Number one, your plan of care, we don't refer to it as a 485 anymore. The 485 is a form that's gone out of vogue. CMS has not endorsed that form for quite a while. And because of several of these locators that were not on the 485, such as psychosocial and emergency room and hospitalization risk indicators, we have gone with a plan of care that is not a 485. Now, it looks really similar because we want to make sure that as far as physicians being able to identify that this is something they need to sign, for example, we wanted it to look very similar, but it will not be a true 485 plan of care. One of the things to remember about the plan of care, if you want to include your certification or recertification statement on that plan of care, which is normally found in locator number 26 and is amendable, you will have to make sure at the end of your OASIS there's a box to check that says include the certification on the plan of care. And if you don't check that, this is not going to show up on your plan of care. If you do check that box, you will have a certification statement that you can amend and put on your plan of care as well. The individualized plan of care must be reviewed and revised by the physician who is responsible for the home health plan of care. Who is certifying your patient for home health, in other words, and then who is going to provide home health care plan oversight. This is very important as well because part of the qualifications for receiving the Medicare home health benefit is that there must be a physician who provides care plan oversight, as well as a physician who certifies and a provider who does a face-to-face encounter with this patient. Now, those may not be the same physicians, so you're going to have to pick and choose which physician is going to be responsible for that home health plan of care and make sure that that's the person, that's the physician who is reviewing and revising the plan of care and signing all your orders that go on the plan of care, unless, of course, there's a different physician adding orders to the plan of care as well. I know that's a little cloudy the way I explained it, but let's say that your primary care physician did the certification for home health and they're signing your plan of care, but you also have an endocrinologist and a pulmonologist who are giving orders during the cert period as well. You would need to list those physicians on your plan of care as well, and then make sure that any revisions are communicated to all of those physicians. It also says here that the agency must promptly alert all the relevant physicians to any changes in the patient's condition or needs that suggest the outcomes that are not being achieved and or that the plan of care should be altered. Again, these are things that clinicians should already be doing. If you're out seeing a patient and the patient's blood pressure is not controlled with current medications, or the wound is not progressing with the current wound care, or something's going on, maybe there is a lack of food in the home that you've identified and that's impeding the patient's progress, all of those changes need to be communicated with the correct physicians so that we can amend our plan of care. We see at 484.60C, a revised plan of care must reflect current information from the patient's updated comprehensive assessment and contain information concerning the patient's progress toward the measurable outcomes and goals identified by the agency and the patient in the plan of care. So again, the revisions, we've heard this in the industry referred to as an evolving plan of care. So we've seen two different things that let us know that this plan of care is a living document, basically. One, we have seen that all verbal orders have to flow onto the plan of care. And that's one of the things we've had some problems with, questions, or I shouldn't say problems, but a lot of questions regarding how that works in our system. And Ms. Shawn Hamilton's going to go over that again this afternoon as far as how that plan of care is going to work and how verbal orders are added. But basically, when you're in the system adding orders, I like to think of it, because I'm an old nurse, I like to think of it as having a Cardex back on the nursing floor. When new orders would come in on the med-surg urology floor, and the floors that you all probably worked on back in the day too, we would remove the old orders that were discontinued and then add the new orders that had just come in, so that on that Cardex at any moment, any healthcare professional could walk up to that and see what was current order, what the current order looked like, what the current set of activities that we should be delivering to this patient were. So in the plan of care, which you have in agency core, it's not going to look like a Cardex, of course, but you are going to have a view so that you can see all of the orders as they've come in by date, as well as any orders that have been discontinued. And they're going to be in two different sections. The discontinued will be below those orders that are current. And the reason for that, when you think about the plan of care and how we used to have to dig through the chart and just look at tons and tons of physician orders to try and find the most recent wound care orders and so on, that would be difficult and things would get missed, or it could be that a clinician had forgotten to write an order, and so all the way at the end of the episode when you're doing a pre-billing chart review, you realize somebody forgot to write a frequency or somebody forgot to do this or that. The plan of care, because it's evolving, what we're trying to do is make sure everyone is working on the most current set of orders at all times, and that anyone can go to that plan of care and get the current set of orders. We see on the second bullet here that any revision to that plan of care due to a change in the patient's health status has to be communicated to the patient, the representatives if they have any, the caregiver, and all physicians issuing orders for the agency's plan of care. Now, you'll need to refer to your agency's policy on what you want to do and how you're going to handle communicating, especially to the physician. But certainly you will need to make sure that your policies include, and that you're, as a clinician in the field, your process includes that you are documenting that you've communicated any changes in the plan of care to the patient, the representative, the caregiver, and then any physicians that are issuing orders. Some agencies have asked whether or not this requires signature from all the physicians. Again, that's going to be an agency decision. CMS has not given us information as to whether or not that needs to be signed. But personally, as an administrator, if I were still running an agency today, I would not be sending all of these orders for updates. You've got your supplemental orders that will be signed. I wouldn't be sending plan of care updates for signature, because that's going to hold up your final bill. But certainly you're going to want to be able to prove the fact that you have notified these physicians of changes in the plan of care. And it's not just the physician who's signing the plan of care, it's all physicians who are issuing orders for that plan of care during this episode. All right, we see under coordination of care at 484.60 that the agency must assure communication with all physicians involved in the plan of care, and that we must integrate orders from all physicians involved in the plan of care to assure the coordination of services and interventions provided to the patient. Again, when you look at the theme of what the updated COPs are trying to do, we see that really we're trying to pull off giving the patient a higher level of quality and ensuring that the outcomes are better. And then we see the patient's involvement through their rights and then the coordination of care. We're trying to involve this patient and their caregivers so that they have increased participation and buy-in, per se, of making sure that they're getting better. We have learned through practice and through research that patients who know what's going on with their care and are invited to participate in their care often will step up to the plate and do just that, and they tend to have better outcomes because they understand. So with the coordination of care, again, we're trying to communicate with the patient all these different things that are going on and what they need to be doing and why. And I can only speak from my own experience. One of the things that I learned as a field nurse, And I kind of chuckle about this because it seems so elementary, but when you're out in the field, sometimes things, are distracting and you don't think about the little things. But I remember being out in the field and thinking about how many more patients I had to see, and Mrs. Jones here had a cough and I needed to let the doctor know about the cough. So I'd tell Ms. Jones, hey, I'm going to call your doctor when I get in the car on my way to see the next patient, and I'd go ahead and leave her house. And then I'd hear back from Mrs. Jones by end of the day, and she'd be asking me, did you call the doctor about my cough? And I'm thinking, why are you asking me that? I told you I would. But oftentimes these patients, they don't know us very well. They don't trust us. They don't know if we called the doctor or not. So what I quickly learned was, as far as satisfaction and involving that patient, I learned to call the doctor from the patient's house. And when that patient could hear me actually calling Dr. Shepard, they knew I did call, and they were less likely to hound me about it, but also they would have the ability to hear if I got orders immediately, and I could communicate that and then document that all on my note. And again, that seems very elementary, but it's all about involving that patient in their care and communicating with them and letting them know what's going on as well. So that's just one example that I thought of in the middle of all this and thought I'd share with you. Bear with me just a moment, and I am looking at a question that has come in. The question is, and I'm going to take this in parts, are we now required to get a signature every time the plan of care is revised? Again, this is going to depend on your agency's policy. CMS does not say you have to get a signature every time the plan of care is revised. But remember, the things that revise your plan of care are verbal orders. So your supplemental order, which will be what triggers the revision to the plan of care, that supplemental order will be sent for signature itself. But as far as sending an actual plan of care every time, that is not required by CMS. You'll need to check your accrediting body standards as well as your agency policy as to whether or not you're going to choose to send that whole plan of care every time in addition to the supplemental order. Personally, I wouldn't do that, but again, I'm not there to see your policy or your accrediting body's regulations, so check that. And then the next question was, are you required to get a signature every time the plan of care is revised, even if it's a change in the medication dosage? Again, if you're going to have a change in medication dosage, that's going to be recorded on a physician's order, supplemental order, and that's where your signature will be recorded, and then that's going to trigger that plan of care update, okay? And then when will a physician's signature be necessary? Since the plan of care must be sent to all physicians associated with the patient, do I need signatures from all MDs before billing? Again, you've got one physician that's doing care plan oversight. You've got other physicians that are contributing to that plan of care. And remember, those supplemental orders or verbal orders, when they are recorded, those have to be sent out for signature verification. So you will have your signatures as you go then. As far as how often you need to get that plan of care signed, if you remember back from that slide, that's pretty much the same as it is now with a couple of exceptions. So basically, once you get the start of care assessment completed and that plan of care is generated, that plan of care will be sent for signature by the physician providing oversight. And the same at recertification. The only changes really, and again, this is going to depend on your policies, would be if you have a significant change in condition, I would send the plan of care at that time for physician signature. And then also if you have a post-hospital change in the plan of care because of a resumption of care oasis, that also will now generate a plan of care for signature. Those are the occasions when I personally would send that plan of care out for signature. As far as all the other physicians that are participating in plan of care changes, again, the supplemental order will be what's used for their signature, but you will have to make sure that, let's say, the endocrinologist changes orders on the patient's metformin. You will have to notify the other physicians that are involved in that plan of care, but CMS does not require a signature according to the interpretive guidance. The next question I have, do we have to get a signature for delivering care summary to the patient and caregiver? I'm not exactly sure what you're asking there, but again, that's pretty much going to depend on your agency's policy. A signature for delivering care summary. I'm not sure what that means. Do you have to get a signature for delivering care itself? Again, that's going to depend on your agency's policy. Many agencies do require a signature or maybe an electronic visit verification. That may not be a CMS requirement. However, it is good practice to ensure you're not accused of fraud. So it was always my practice to have clinicians get a signature for care delivery. And whether or not the patient and caregiver needs to get a signature. Again, it has to be documented somewhere that you're communicating with and that you've delivered things like patient rights. But as far as getting a signature, that's going to depend completely upon your agency's policy and or your accrediting body's standards. And then I have a third question here. Just a clarification, is the quarterly clinical review still required by CMS? That is a lengthy explanation, and the best thing that I could recommend for you on that would be to tell you that the QAPI standards have completely changed. As far as requiring a certain number of charts be reviewed each quarter, that is not in QAPI, but QAPI has become much more in-depth and data-driven. So your best course of action here to find out more about what's required from your QAPI and clinical review would be to go to our on-demand library and look for the COP session. There's 7 there. Look for the COP session on QAPI and listen to that so that you know what all of the QAPI requirements are and are not. Okay? And I think that's all the questions that I see so far. We'll get back to those as more come in. But let's resume our coordination of care talk here. Again, all those changes in the coordination of care have to be communicated to the patient, the caregivers, the representatives, and all the physicians. Now we see at 484.60D in coordination of care, the agency must integrate services, whether those services are provided directly or under arrangement, to assure the identification of patient needs and factors that could affect patient safety and treatment effectiveness, and the coordination of care provided by all disciplines. The main takeaway from this slide is just that the coordination of care is the responsibility of all the providers. Whether you are directly employed by that agency or whether you are a contractor, it doesn't matter if you are full-time, part-time, PRN, per visit, or contracted staff. CMS requires us to identify patient needs, to identify things that might happen as far as patient safety issues, treatment effectiveness, and the coordination of care. So everything from the identification to the recording of this in the records is a responsibility of all the disciplines, regardless of your employment status. The only time that wouldn't be affected for you would be if you're not employed by the agency. And I don't mean directly, I mean at all. If you're not seeing the patient, then you don't have to worry about it. Otherwise, you do. At 48460D, we also see that the agency must coordinate care delivery to meet the patient's needs and involve the patient, the representative, and caregivers as appropriate in the coordination of care activities. Something to point out particularly about this statement, in the Q&As that came with the final rule on the COPs, as well as the draft interpretive guidance, we saw care delivery and coordination addressed very often. One of the points they made as far as patient preferences and care delivery was, for example, if the patient wants to have a bath in the morning instead of the afternoon, the agency should accommodate that request. And again, those are things that you may have to look at changing the home health aide out who's going to go because they can't get out there in the morning. But what they're telling us is that we have the responsibility to meet that patient's needs and involve them and accommodate their preferences as much as possible. Another example they gave was if you have a patient, for example, who has the home health aide come right before the therapist comes, and the bath with the aide tends to wear them out so that they can't fully participate in the PT treatment that afternoon, that you're going to want to reschedule that care so that the patient gets the best benefit from physical therapy. So again, we're seeing all kinds of more stringent efforts being made to making sure the patient's receiving the care that they need in a way that they're going to achieve outcomes. I see another question has come in regarding QAPI. It says, how often should the QAPI be done? Again, this is going to be something that you're going to need to do a whole QAPI session on. I would again refer you to the on-demand library with the QAPI. CMS has not given you a standard as far as how often. What they've done, instead of telling you how you're going to do QAPI, they've told you that this is what they want to see happening in the QAPI environment. They want to see data-driven data. They want to see that you are identifying potential issues like high risk, high volume, or problem prone areas, and that your QAPI is doing what you can to ensure that those are not problems. Some agencies will choose to do their QAPI twice a year, some will choose to do it quarterly, some will choose to do it monthly. So it's going to really fall upon you as an agency to get to know what it is particularly that you're having issues with, and then how often you need to analyze that data and do your QAPI. Okay? Again, go to our Axxess.com website. If I can get one of the other coordinators or organizers to type in that link for our 7-part COP series. If you'll look in the questions when that comes in, click on that link, and we'll make sure that you know where to go and get on that QAPI webinar. Okay? Thank you very much for the question. We see here that the agency must ensure that each patient and his or her caregivers, where applicable, receive ongoing education and training provided by the agency as appropriate regarding the care and services identified in the plan of care. The agency must provide training as necessary to ensure a timely discharge. Again, we talked about this a couple times in the patient's rights, and then the comprehensive assessment, and then even over into the plan of care, where we talk about making sure that we have patient-specific care and services identified, and that the patient has the right to receive all of the stuff that's on their care plan. We see here in the coordination of care that we have to ensure that they receive ongoing education and training regarding the care and services identified in that plan of care. So you're seeing how this is tied throughout all of the regulation, that this has to be patient-specific care, it needs to be individualized, and then we have to make sure that we're delivering the care that we said we were going to deliver. Written information to the patient. This standard 484.60E was not in the proposed rule, by the way. We saw 484.60E come about in response to questions and answers that were sent in by agencies after the proposed rule came out. And then when CMS did their question and answer session and posted that in the final rule, written information to the patient was a new standard that they had included. The reason for that, CMS had said in the proposed rule that each patient should get a copy of their plan of care and that it should be left in the home. And I think many of us may have read that and didn't read any further, because I still get lots of questions about this. CMS came back and said in their Q&A in the final rule that because of the questions and some of the concerns that agencies had regarding leaving a true plan of care in the patient's home, and the concern was that it contains a lot of jargon that the patient might not understand, CMS said, you're right, really you don't need to leave the whole plan of care there. There's information there like a certification statement or all this other stuff that the patient just does not need. Instead, what we want to do is have written information to the patient and the caregiver, and this is what specifically they feel that we need to have written and left in the patient's home. We see that we must leave a copy of written instructions outlining the patient's medication schedule and instructions, the medication name, the dosage, and the frequency, and which medications will be administered by agency personnel. Now, when you're leaving instructions in the home, remember CMS is telling you here this needs to be in simple English so that if the patient goes and looks at this written information, they know where to find it, they understand it when they read it, and they can follow the directions. Specifically, CMS has said that means no abbreviations. So we wouldn't expect the written information on the med profile to say ASA for aspirin or PCN for penicillin and so on. You would want that medication name written out fully. And then the dosage, 1 tablet, not 1 tab, or not the little, looks like a lowercase I for 1. You're going to want to write that out, 1 daily by mouth. Not PO, but by mouth. And then you also have to include which medications are going to be administered by agency personnel versus which medications are going to be administered by the patient or the caregiver. All of that will need to be left in the patient's home, as well as any treatments that will be administered by the agency personnel. That is more written information that has to be left in the patient's home. When you're thinking about treatments, don't just think about things like wound care. Think also of your modalities for therapy, things like percussion or ultrasound. Those are treatments as well, and you'll need to write that out and leave that information with the patient and the caregiver as well. Home exercise programs and so on. And that's one that we often are most familiar with leaving in the home now. We also see the agency has to provide the patient and caregiver with a copy of written instructions outlining any other pertinent information related to the patient's care and treatments that the agency will provide, and it has to be specific to that patient's care needs. So if you're talking about doing infection control teaching, we're going to talk about that in just a moment, and you're teaching that patient on how to clean their glucometer or their nebulizer mouthpiece, then those written instructions would also need to be left in the patient's home with step-by-step directions that are specific to their care needs. A new standard we have here as well, we must also leave in written form the name and contact information of the agency's clinical manager. Now remember, the clinical manager role is new, and when they're talking about the name and contact information, we see from the interpretive guidelines that once that comprehensive assessment is completed, the documents mentioned in the written information to the patient, that's when those documents have to be provided to the patient. So it may not be the very first day on the initial assessment. It may be after the comprehensive assessment is completed. I wouldn't let too many days go by, however, from the time that comprehensive assessment is completed to when this makes it in the home. That would be an issue. And then we also see that clear written communication between the agency and the patient representative ensures that patients and families understand what to expect. We see that the written information to the patient, according to draft interpretive guidelines, must have the most current written visit schedule provided to the patient, and that has to be consistent with the most current plan of care. Let's stop a moment and talk about that for just a second here. Remember your visit schedule if you're doing this on start of care and you have physician orders that change that visit schedule. Remember, because of the coordination of care piece, you have to notify the patient. I want you to think about informed consent. We always get that at start of care, but CMS has come back and told us throughout this new regulation that informed consent is an ongoing process. You don't want it to look like the only time you informed that patient and got their consent is in the very beginning. Remember, when we talked about coordination of care and patient rights, the patient has the right to participate in their care. So you're going to want to make sure you've documented that you talked about the frequency change, the patient consented to that frequency change, and now you've given them a written copy of that most recent visit schedule. According to what's required at 484.60E, we have to have a written copy of that visit schedule that matches the most current plan of care. So make sure this is kept up to date in the patient's home. We also have to make sure when there is a med change, we had questions about the orders just a little while ago, we also have to inform the patient in writing when that patient's med regimen changes. Again, you've got to leave written instructions on that medication regimen, so you're going to have to keep that updated as well. And then it tells us here in interpretive guidance, this is where I told you just a minute ago, written medication information must be in plain language and should avoid using abbreviations. That's new regulation from the draft interpretive guidance, but it has been a regulation for the Joint Commission for many years now, that they could not use abbreviations in their medication list for a long time. For the clinical manager, when they talk about leaving the name and telephone number of that clinical manager, again, they're talking about the name and then the telephone number at the business address, or the business phone number rather. And then it says you can also give the email address of that clinical manager if you want to. But then the agency should document, because CMS tells us here, the agency should explain when the clinical manager should be contacted for discussion regarding their services. So not only are you just going to hand them a phone number, you're going to be talking about and documenting how you explain to the patient when it's appropriate to call the clinical manager. Let's get into for just a moment 484.70, infection prevention and control. We see 3 standards here regarding infection prevention and control. First of all, we talk about prevention, and it tells us that the agency must follow accepted standards of practice, including standard precautions, hand washing, to prevent infections and communicable diseases. So you're going to want to make sure that you're documenting that standard precautions were followed, that hand washing was practiced, and so on. The second standard we see here is control. The agency has to maintain a coordinated agency-wide program for the surveillance, identification, prevention, control, and investigation of infectious and communicable diseases, and that it's integral to your QAPI program. Again, we're pretty much accustomed to recording infection controls logs and then watching those and maintaining and commenting those. What CMS is doing now, they've taken that a step further and made sure that if you have some problems with infections, that as part of your QAPI program, you're trying to identify what those risk factors are, or seeing if you can identify any trends. Maybe there's a particular nurse that keeps having patients with infections, or a particular nurse has lots of patients with MRSA that's contracted during their care. You're going to want to get to the bottom of that and show that through your QAPI program. The last standard we see here, I'm going to skip that slide real quick, is education. We see that the agency must provide infection education to staff, patients, and caregivers. And what they're talking about here is including the appropriate use, transport, storage, and cleaning methods of patient care equipment. So, you go in to see a patient and you notice they have a glucometer and it's smeared with blood, or that they're throwing their Lancets and their chem strips in the trash can without putting them in a biohazard container or a puncture-proof jug. You're going to have to make sure you're documenting and teaching them on infection control. We see that we must, as an agency, also provide education that's job-specific, infection prevention education and training, and you're going to want to make sure that you have sign-in sheets and proof that this has happened, and this is in your HR folders for each of your employees. And when it talks about staff, again, remember they're not just talking about your full-time or part-time staff, they are including your contracted therapy staff as well. So make sure that you are doing education to all staff and that you have this documented in your HR records and or your contracts with your contracted therapies. And then last, the process is to ensure that all healthcare personnel understand and are competent to adhere to infection control measures. The last thing I want to go over before we conclude our webinar and get to any remaining questions has to do with the skilled professional services. At 484.75, we see the skilled professional services are defined as skilled nursing, PT, speech-language pathology, occupational therapy, and social work. Now, skilled professionals, and they do clarify that this means direct or under arrangement or contract, must participate in the coordination of care. Those days when the make-a-visit mentality was rampant, where you would have clinicians going out and seeing a patient, and you wouldn't know anything that happened until 2 weeks later when they sent in their paper forms to be uploaded and to get paid, those days are gone, unfortunately. I say unfortunately for us because we have a lot to juggle, but fortunately for the patient's care, this is a good thing, because the more we coordinate care and talk about with our other disciplines what's going on with our patient and share what they're seeing, the patient's care can only be better, right? We must make sure that the qualifications of these skilled professionals meet the qualifications at 484.115. By the way, I would add these qualifications as well as the standard here where it says skilled professionals must participate in coordination of care. That would be on my job descriptions and requirements whenever you're filling out an application. That would be in that information as well as part of the job requirements. We see that CMS also tells us skilled professionals assume responsibility for ongoing interdisciplinary assessment of the patient, development and evaluation of the plan of care in partnership with the patient, representative, and caregivers, and that the skilled professionals are providing services that are ordered by a physician as indicated in the plan of care. Again, basically, if you're going to choose to work in a home health setting, you are responsible for all of these things. You can't just run in and take vital signs and leave and go on about your merry way. You are responsible for interdisciplinary assessment and communication, coordination of care, developing and evaluating this plan of care, which, by the way, I've seen clinicians go in without even looking at a plan of care and deliver services. Again, you can't evaluate the plan of care if you don't know what's on it, right? And we have to ensure that this patient receives all the services on the plan of care, so that means our processes are going to have to be tightened up, that the plan of care is generated quickly, and that every clinician has the ability to view that plan of care, which is why you see some of the new revisions to functionality that Ms. Shawn's going to go over again this afternoon. All of this is to make sure that we're compliant with these COP regs. We also see that skilled professionals assume responsibility for patient, caregiver, and family counseling, patient and caregiver education, preparing clinical notes. Yes, it's even in a COP standard now that you have to get your notes done and turned in timely. And then communication with all physicians involved in the plan of care and other healthcare practitioners as appropriate related to the plan of care. Skilled professionals assume responsibility for participating in the agency's QAPI program and participating in the agency-sponsored in-service training. So again, I just want to reemphasize that we're not talking about making a visit. You've got a lot of responsibilities, and I know we feel these responsibilities because I've worked in the field for many, many years. There's a lot that we have to do as clinicians. So administrators, I want to take a minute and speak to you. Make sure, because you realize all of the responsibilities that are on your field clinicians, please don't set them up for failure. Please give them adequate time and reasonable productivity scales so that they have the adequate time to do what's needed to do to make sure they're ensuring all of these things happen. We see at 484.75 the skilled professionals have to supervise the other services, and we know this already. This hasn't changed. Nursing services must be under the supervision of the RN. Rehabilitative services must be under the supervision of an OT or PT, and medical social services must be under the supervision of a social worker. The contents of the clinical record here we see at 484.110A. The record must include all of the patient's comprehensive assessments from their most recent admission, clinical notes, plans of care, and physician orders, all interventions and responses to those interventions, medication administration, treatments, and services. The record must also include goals in the plan of care and the patient's progress in achieving them. And we've already spoken to that. Again, you should be showing progress to goals in each note so that when the discharge happens, it doesn't look like a miracle occurred and it's a big surprise. The record must also include contact information for the patient's representative if they have any, and the patient's primary caregivers, contact information for the primary care practitioner or other healthcare professional who will provide care and services to the patient after agency discharge. And the draft interpretive guidance tells us about that last point here, that if the patient identifies an attending physician who will resume care after the agency episode, the contact information should be included in the medical record. So basically, you're trying to deduce who is it that that patient goes to see on a routine basis. Who is their primary care physician? And the reason for that, on discharge, you're going to have to communicate with that provider and let them know a summary of the care that you've provided, what you've done for that patient, so that they can ensure that the patient follows up with, all of the things that we've taught, and that they're continuing to monitor themselves and manage their chronic conditions as well. And it says it doesn't matter if the physician that we record as the attending physician, it doesn't matter if that's the responsible agency physician or if it's somebody else. We also see the record must include a completed discharge summary that has to be sent to that primary care practitioner. We just talked about that. And the discharge summary has to be sent to that primary care practitioner within 5 business days of the patient's discharge. Discharge summaries typically include your admission and discharge dates, the physicians responsible for the home health plan of care, the reason for admission to home health, the types of services provided and the frequency of services, lab data, medications the patient's on at the time of discharge, the patient's discharge condition, the patient's outcomes in meeting the goals in the plan of care, and any patient and family post-discharge instructions. Remember that discharge summary is sent to the primary care physician or primary care practitioner within 5 days from the date of the order for discharge. So again, this is not 5 days from the day that you made the discharge visit, but 5 days from the day that you took the order to discharge this patient. So you're going to need to schedule your discharge accordingly. The record must also include, when it's appropriate, a completed transfer summary. Now, if you're doing a transfer summary and the patient's going to receive care in a facility, you have to send that transfer summary to the facility within 2 business days of that planned transfer. However, if it's one of those situations where you don't know that the patient transferred, they're back at home and already out of the facility by the time you're notified or by the time you find out, you don't have to send that transfer summary. If they're still in the facility when you find out, you have 2 business days from the time you became aware of them transferring to get this transfer summary over to the facility. But as far as if they've already come home from that facility, you don't have to send the transfer summary in that case. But make sure you document very well what happened to keep yourself out of hot water there. And the contents of your transfer summary typically is the same stuff as what you're going to put in a discharge summary. So make sure that that's correct as well. At 484110B, authentication, it tells us the entries in the clinical records must be legible, clear, complete, and appropriately authenticated, dated, and timed. You're going to see some functionality changes in Agency Core because of authentication standards. For example, the appropriately authenticated, dated, and timed functionality will change in the QA Center in so much as if you go in and amend someone's records, you're not going to be able to make it look like that person did the changes. If I go in on Miss Shawn's record and amend something, you're going to see Shawn's signature followed by my signature that I made those changes. And that's appropriate and legal. Again, if you were documenting on a paper document, you certainly wouldn't have Shawn come in on my paper document and mark through things and change them and write on that paper document. An electronic record is the same, legally speaking. You don't go in and willy-nilly make changes on things that were not your assessment to begin with. So again, that has to be properly authenticated, dated, and timed. The functionality has changed a bit in our system to accommodate these criteria. Authentication must include a signature and a title or your occupation, or a secured computer entry by a unique identifier of a primary author who has reviewed and approved the entry. Again, this goes back, and I hear this happening every once in a while, and I still can't imagine this goes on, but each person who uses an EMR, whether that be Axxess or whomever, you have your own unique identifier. You have a unique login and password. Do not share that with anyone. That is your way to authenticate that this is your record, that you actually wrote this information. If you give someone else your login and password, they can go in as you and write Lord knows what, and then you're legally bound to that. So again, make sure that you have your unique identifier, you don't share that, and I would even go so far as recommend that you change your password often. If you have policies about changing your password, make sure you're following those policies. For example, if it says you're going to change it every 30 days, make sure you do that. Okay, and I have a question that's come in here. It says, do we have to give written information to patients upon start of care for just the clinical manager's name, contact, and address, but do we also need to include the information for administrator and DON? It talks about the clinical manager for sure. Again, you're going to want to refer to your agency's policies and your state requirements, because your state requirements may require that you give more information than just the clinical manager. For example, just because we're giving the clinical manager's name, that does not absolve us of using the state hotline number and notifying the patient of the state hotline number, for example. To get a complete list of what all you need to leave on the start of care, make sure you go through those 7-part series that we referred to earlier on the COP training, because that's going to go through each part of the COPs, and each section may have a little bit different requirement. But a complete review of the patient rights, for example, is going to tell you what all you need to leave in the patient's home as far as contact info. But again, remember, there's layers of regulation, because you may have federal standards that we see here in the COPs, but you may also have additional requirements from your accrediting body like Joint Commission or CHAP or ACHC, and even state standards. So again, you have to make sure you're reviewing all of that. And that's the only question that I see just yet. I know we're over just a little bit. We're about to wrap up. So if you do have some questions, please go ahead and submit those now so we can get those covered before we go offline, okay? Lastly, for retrieval of clinical records at 484.110E, we have that the patient's clinical record must be available to the patient on request. It can be hard copy or electronic, but it has to be given free of charge. And if the patient requests their records, you have to make sure that you deliver those records by the very next home visit or within 4 business days. You need to make sure, and that's whichever comes first, by the way, you need to make sure you're educating your staff about this requirement. Because if you have a situation where the home health aide goes in at 8 o'clock in the morning and the patient mentions to that home health aide, oh, by the way, I need a copy of my medical records, and you've got a nurse coming at 9, if that nurse goes ahead and makes that second visit, that next home visit, and there's no record delivered, you're not going to have met this requirement, the standard. So you're going to have to make sure they know to notify you right away, and you may have to coordinate care and tell the nurse to hold off and come get a copy of the record or whatever, to make sure that you're ensuring this standard gets met. So again, as we see here, questions or comments are welcomed. I don't see any more questions at this time. I do have my contact information here should questions arise after the fact. You can email me at jgibson@axxess.com, or you can call the number here to the office and punch in the extension 3917. That will get you to me or my voicemail, depending if I'm on the phone or not, and I will try and return those calls as soon as I possibly can. Also, our co-organizers have put in the question box in your toolbar for GoToWebinar links to both the blog series that we have had as well as our on-demand content. These webinars that are being presented last week and this week are also being recorded and archived and will be on our on-demand content page, on our Help Center in the Axxess Agency Core product, as well as on YouTube eventually. So make sure you're checking all of those different sources to get the information that you need. We want to make sure that we support you and help you to be prosperous and to be compliant here at Axxess. We're happy to help you as much as we can and however we can, but certainly know that all of those resources are not going to be live. There are some on demand and archived as well. I have another question about what about the PAC? Is it already removed? I think you're talking about where the conditions of participation have changed the terminology from your PAC committee in the administration of the agency. They call it now the governing body. You're going to find the standards as far as the administration of the agency in subpart C of the conditions of participation. We're not going to get into that particularly on this webinar because it doesn't affect the functionality of the agency core product. But the PAC committee has been replaced by the governing body, and as far as what that governing body is responsible for, including approving the QAPI projects and the oversight of the agency, you're going to find that in that 7-part series, and you will also be able to find that in subpart C of the actual conditions of participation regulations as well. Okay, and then I've got where can we get a copy of this morning's webinar. My co-organizer is letting us know that our marketing team will be sending this out later today, as well as the slides from today's presentation. So you will need to check the email address that you used to register for this webinar. That's where that information will be sent out, okay? With that, I think our time is up for today. We've actually gone over a little bit, but I want to take a moment and just thank you. If you've listened to me before on webinars, I like to take a moment always and thank those of you who are working today in home health, because we know that we have patients at home that deserve to be seen about at home and deserve the care that they need in their home. And we know that no matter what job you do at your agency, if you weren't there doing that job, those patients would likely not get the care they receive. So take it from old Jennifer Gibson. If nobody else thanks you today, I did. Thank you for doing what you do and for taking care of our patients. We hope that you'll join us again this afternoon for the functionality presentation that will be given by our product manager, Ms. Shawn Hamilton, who's also a wonderful RN with lots of experience in home health, and she's going to be going over with you the functionality changes in agency core as well. So we hope to see you back. Have a wonderful day, and let us know if we can help you again in the future. Thank you so much. Bye-bye.